Hello, this is Ryan Williamson, and today we're going to talk about a case study involving a chronic cough with hemoptysis or blood in the cough. We're going to look at the case, then talk about the microbial pathogen that's involved before looking at the specific disease characteristics and then diagnostic techniques used to diagnose that disease. Then we're going to wrap up with talking about prevention and treatments of said disease. So we'll start with the case. We have a 19-year-old female who's presenting for a routine physical at her primary care physician after finishing her first year of college. She's just gotten back from school, and she's not feeling well. She has a mild cough, some fatigue. Her cough's been around for the past 2 weeks, and she's pretty tired, as one would imagine, from finishing her first year of finals. The primary care physician examines her lungs, and he determines that they're clear on exam. She's got no fevers at the time, and despite the cough and fatigue, she's overall pretty well appearing. Now, mom's with her in the room during this exam, and during the history, the provider asks if she's been out of the country lately. The female patient here denies it, kind of looking to scamp, but says no, she hasn't been out of the country. So it seems like a pretty clear case of a viral upper respiratory infection. There's really nothing that they can do in terms of treatment-wise for this other than symptomatic care. So that's, rest, pushing fluids, things like that, cough and cold medications over the counter, but otherwise there's really nothing much they can do. Now she goes home, and unfortunately her symptoms only get worse over the next few days. She runs a fever, she starts having terrible night sweats, and then she has blood in the cough. Now the blood in the cough is what alerts her mom. She says, you got to get back in. She goes to be seen at the clinic. Now at the clinic she's weighed, and they found that she's lost weight, and on exam her lung sounds are decreased in the upper lobes. Now this is really troubling to the physician, as you'd imagine. And he asks her again, are you sure you haven't been out of the country? And this is when the patient breaks and goes, yes, I have. I lied to my mom. I actually was in Brazil for spring break. Now this changes everything. Physician then orders an interferon gamma release assay for her blood labs and then sends her to the hospital for a chest x-ray that day. The chest x-ray comes back. We see here a right upper lobe density. The blood work was positive for tuberculosis exposure. She then started on isoniazid and rifampin, pyrazinamide, and ethambutol for 2 months, but then having a 4-month follow-up treatment of just the isoniazid and rifampin. So here we got a pretty clear-cut case of tuberculosis. Now we're going to dive in a little bit more about the specific microbe involved in this pathology. So tuberculosis is caused by a bacterium called Mycobacterium tuberculosis. This is a non-spore-forming, obligate aerobic, facultative intracellular bacillus. Long story short, rod-shaped, needs oxygen, would prefer to be inside the cell, and doesn't form spores. Now, there's something unique about it in terms of other microbial structures. It doesn't. It has mycolic acid in the cell wall, so it can't be identified through gram staining. Rather, you use acid-fast stains or fluorochrome stainings to really identify this. And then it's notoriously a slow grower in culture, so there's a few different culture types specifically that are used to increase your success of culturing this, but it takes sometimes 18 hours or so, a lot longer than your typical microbes. Now, what's interesting is the history of this bacterium is that there's actually skeletal findings date as far back as 4,000 years ago showing evidence of skeletal tuberculosis. So a little bit further along, you see mentions of bloody cough and wasting away, mentioned in the 7th century Assyria timeline, but also in the 5th century Greece by who we see here on the right, Hippocrates. Now, that's quite a long time to be noticed about, but it really wasn't, the disease itself wasn't linked with the pathogen until the 19th and 20th centuries by Williamson, Koch, and finally Trudeau here, who's pictured on the right, who was finally able to link it by giving rabbits inoculations of the Mycobacterium tuberculosis and actually seeing the progression of TB. Now, recent genetic analysis and genomic evidence has shown that the Mycobacterium tuberculosis is actually part of a complex. So these 4 other bacteria, Mycobacterium africanum, Microti, Candida, and bovis, all share a 99% genetic match with Mycobacterium tuberculosis. So it's all idealized. It's very similar evolutionarily from these microbes as well. So now we're going to talk about tuberculosis, the disease itself. A little quick statistics here for you. The CDC reports that about a quarter of the global population is infected with TB. So this is one of the most deadly diseases in the world. 1.7 million people died in TB-related deaths as of 2016, again reported by the CDC. In terms of pathogenesis, the bacteria typically enters the airway, in cases of pulmonary tuberculosis, enters the airway through aerosol droplets of infected individuals. And then the bacterial stick to the mucosa along the respiratory tract and then get phagocytized by macrophages in the area. Now, if you remember, they're facultative intracellular bacteria, so they want to be in there. They can actually evade the immune system in this way. Now, if they're not cleared, sometimes they're cleared, and the person doesn't develop disease. If they're not cleared, they lead to lesion formation in the lungs. There's two main types of lesions. There's exudative, which is characterized by inflammation and edema to the lung, and then productive, which is kind of a more longer-lasting lesion. Typically, you see they're called hard lesions. The bacteria is sequestered in the center of the lesion, and it's surrounded by both endothelial light cells and then different types of phagocytes as well. And on the right here, we see a distribution of TB mortality. So really, really high distribution in Africa. There's a correlation with AIDS because that is HIV rather, because that's an increased risk factor. And you see that it's endemic in certain areas, so Brazil, Africa, things like that, but not in North America, or at least not in the United States. So in terms of the symptoms, for pulmonary tuberculosis, the symptoms are weight loss, fatigue, chronic cough with hemoptysis, again, that's blood in your cough, and then night sweats and fever. Now, important to note, the infection actually remains latent for years before reactivating. So someone can be asymptomatic for years. When it's a latent infection, they're not contagious. But then if that tubercle, so those lesions in the lungs can be called tubercles, those can be jacked up by a motor vehicle accident or any physical blunt force trauma. And that can release the bacteria into distribution and actually cause the latent infection to become active. In addition to the pulmonary symptoms or pulmonary infections, TB can also be spread to different tissue types. So you can see it in cardiac tissue, brain, it can cause meningitis. You can see it in bones as well, and that the bone infection is what they found evidence of 4,000 years ago. You can also see it infect the GI tract and then the genitourinary tract as well. Now, to diagnose it in North America, or at least in America, the most standard diagnostic technique is the Manto TB test. This is when they inject tuberculin, a protein from the microbe under the skin. It's a subcutaneous injection, and then they read it in 24 or 48 hours to see if you react. And if you do react, it's a positive test, and that means that you've been exposed in the past. However, the problem is some folks did a vaccine. We'll talk about that later. And they did a false positive. So an interferon gamma release assay is an alternative for that. The labs can involve an acid-fast sputum smear and culture, which is great because it's pretty fast in terms of the sputum smear, but you need a high bacterial load. You can also do PCR analysis, or you can now analyze the cerebrospinal fluid in your analysis for extrapulmonary infections. And then the standard follow-up diagnostic is imaging. So typically it's a chest x-ray or a CT scan seen here in the bottom right. Now, in terms of prevention and treatment, again, as mentioned previously, there is a vaccine for this. It is the BCG vaccine. It's actually from the similar bacteria, Mycobacterium bovis. However, it has a minimal effect. It really is not effective for pulmonary TB. It's mostly effective against meningeal TB, so brain infections, especially in the youth. So it's used primarily in endemic areas, not primarily in the U.S., and that's because it negates the TB skin test, and that's one of our main diagnostic techniques. The treatment for TB, both latent and active, is long-term combination antibiotic therapy. In latent TB, you're going to see your isoniazid, rifapentine, rifampin, and this is anywhere from 3 to 9 months. Now that typically it's 6 to 9 months, 3 months just for younger patients, and the dosage changes whether or not the patient is pregnant and their age. Active TB is a lot more intense. You have 2 months of a rigorous combination therapy, typically involving, again, isoniazid, ethambutol, pyrazinamide, and all of them combined. And then that's 4 or 4.5 months is a little bit more of a maintenance medication. It's important to know there are several at-risk populations: HIV infected, babies, younger children, elderly, IV drug users, the immunocompromised, and then also those who have not been treated correctly for the TB in the past. So the main way to kind of avoid getting TB in the first place is to avoid endemic areas like Brazil or Africa. And if you are exposed, you want to start prophylaxis really soon if you're in one of those at-risk populations. So that's my case study. I really appreciate your time. And these are my references. Thank you so much. Take care.